I am super, super excited to have this conversation with some amazing, amazing people. But before we kind of get started and get everything together, I first want to introduce myself. My name is Sofia Rosales. I go by she, they pronouns. I also work at Prism Health, North Texas. Yay, Prism Health. Mm-hmm. And today I am facilitating today's virtual town hall on women's sexual and reproductive health. I am here accompanied by some 3 really awesome people, but I am going to let them introduce themselves. So I just want you guys to kind of tell me, like, what you do, your name, of course, why you were here having this conversation, what resources you offer, just kind of the whole spiel. So I'm going to let's start off with Melissa.
Hi, everybody. I'm Melissa Carr. I'm a social worker in LMSW at UT Southwestern. I specifically work on Project Safe Connect. It works with cisgender and transgender women who are either living with HIV and have experienced intimate partner violence, sexual assault, interpersonal violence, or women who have experienced IPV, intimate partner violence, and are at risk for HIV. So we're looking at the link between the two. Unfortunately, because statistically women living with HIV are at higher risk for IPV, and women who are experiencing IPV are higher risk for HIV. And I think some of the questions we'll talk about later, we'll go in. I can go into why exactly that is and kind of hit those links. But we have quite a few services available. Again, we're looking at the link between the two. So we're studying that and also offering some services, some case management for those women and trans women that might be experiencing any type of violence in their lives or at risk for HIV. And also, and then we offer community education, because to stop intimate partner violence, which is unfortunately is perpetrated against everybody, but statistically women are, the higher number. Mm-hmm. You have to involve men. You're never going to stop violence against women without having men involved. So we're just educating what that looks like. And we're talking to men about how to speak up against it and to their peers, how to talk to other men, how to talk to their teenage sons, and then also how to talk to teen girls and adult women about what a controlling relationship looks like, or how does that happen, and stuff like that. So we do some community education on that piece, some linkage to care if it's needed, and then we have some great subcontractors that offer emergency counseling or emergency shelter, long-term counseling, and things like that. So that's what Safe Connect does. And like I said, we're really looking at the link to see if we can't find anything that can maybe prevent some of this in the future.
That's amazing. Thank you so much for saying all that. I love how you're advocating and doing all the education, because we forget that component a lot of times, I feel like.
Yeah, sometimes we're reactive, right? And we're just trying to help, but we gotta try new avenues.
All the missing pieces, putting them together. I love it. Thank you so much. So let's follow up with Amy.
Hi, my name is Amy Berrier. I'm a family nurse practitioner, and I work at Prism Health. I have worked there since 2014. After working there 2008 to 2010, I came back because working with the HIV positive population is absolutely where my heart is. I started out as a nurse originally in the ER and kind of landed in HIV by accident, and absolutely fell in love with the patients that we take care of. And I started out as a medical case manager doing the RN medical case management work with the patients, helping them with the referrals, with medication education and adherence counseling and the like. And as I finished nurse practitioner school, I continued working at Prism. I almost said AIDS Arms. We transitioned from AIDS Arms to Prism about 3 years ago now, I think it happened. So I, in my patient population, I take care of both our HIV positive patients. I take care, and we, through Ryan White, provide primary care for those patients who do not have access to insurance and have limited resources. I also provide PrEP services for patients who are looking to be on a medication to prevent HIV infection, and we'll talk about that a little bit later. And I also, in one of my other hats, I also do our transgender hormone, transgender non-binary patient hormone therapy clinic. So I take care of patients that run the gamut of the gender spectrum, and take care of their healthcare needs and their hormone management and so forth. And that's it.
That's it. That's a whole bunch. That's a lot. We commend you for all the work you're doing, because that's a whole bunch. When I start adding stuff to my list, I'm already overwhelmed. And last but not least, Helen, I would love for you to introduce yourself as well.
Sure. Thank you. Thank you for having me. My name is Helen Zimba, and I work for the Afiya Center here in Dallas. And the Afiya Center is the only reproductive justice organization which is led and found by women, and also taking care of the women in the community. So because it's a reproductive justice organization, the HIV part came by, after responding to the needs and the high numbers of people living with HIV needing some services. So we started doing HIV services. So we respond by, taking care of their needs, of working with the other organizations, because we do not provide direct services. We work with other organizations like Prism and everybody else in the community, because all the clients belong there, but we work together. We do HIV in a way that we do trainings, we do education, and it's our job to know about the services that are going on in the community, so that we can make referrals that are, specific to our clients. Mm-hmm. Our clients are everybody's clients, like I said. Mm-hmm. We get, not just women. We got, women with a trans experience. And again, we're talking about, men. We're finding that we're working with men too, because sometimes the women are coming with the men. Mm-hmm. And over the years, things have changed, because as you know, with the HIV, the needs have changed in the community. For some of us who have been doing this work for a while, now we have to change. So we have to keep up with the education. So soon we will be the people that people would go to. The reason why people come to the Afiya Center is because we are not funded. We are not Ryan White funded, so we're not restricted to the things that we can do. So we do everything. As a reproductive justice organization, we do everything. We have voter engagement. We have our policy department. We also have Afiya Talks, where we just discuss issues. And pretty much there's nothing that we cannot do at the Afiya Center, because when we look at reproductive justice, we're talking about everything. Mm-hmm. Because, to end HIV, we cannot do it if we don't take care of the issues that are bringing HIV, which means people need housing, they need, clothing, they need healthcare, they need everything, to go on. And also, as a reproductive justice, we do care about their choices. So if a woman comes to us to say, it's either they have the right to vote or not to vote, to take medication or not take medication, they have the right to have children or not to have children. But at the Afiya Center, our job is to make sure that we are working with our clients in the things that they want to do, but doing it in the way that is healthy for them. Mm-hmm. So, we don't restrict ourselves to doing HIV, to be in the HIV only, because when somebody needs housing and there's not housing that's attached to HIV, we should be able to do that too. So we are pretty much spread out. Mm-hmm. The most thing that we've done with the HIV, there's a program that we do, is called Living Out Loud. Mm-hmm. So Living Out Loud, it's a program that we work with women like for the whole year, with series of modules. We talk about the policies because people don't need to know that they have the right, so they shouldn't be discriminated to get the services they need. Again, that means healthcare, housing, food, regardless of their race, gender, or economic status. So we teach about that in that class. And we also teach about healthy living, because we know that in order for you to stay healthy, you got to live healthy. So we talk about that as well. And also to talk about how they can tell their own story, because nobody else can tell your story but yourself. So there's a lot of things that we do in there, and it's not only for people living with HIV, it's just for advocates, because we need advocates, so you can't just say, we can't living out loud with HIV. No, you live out loud in everything. You live out loud to be Black. You need to live out loud to, to choose or whatever you do. So it is living out loud for everything. So that's what we do at the Afiya Center, and we're so proud that we do a lot of advocacy. Like today, we were busy, advocating, like talking about the issues. And if we have people who are able to speak on the issues that matter to them, we want them to be able to talk about those issues freely without being judged, but we have to prepare people, and that's what we do. So that's just the short, thing about the Afiya Center. We are like really family-centered organization.
That's wonderful. The Afiya Center is magic to me. I just love you guys. You guys are magical. I really love some of the things you said, like walking with your clients. I think that is such a beautiful way of saying that, because we can't tell anybody what to do, but we can simply just guide. We can walk with them. I think that was really beautiful. Before we kind of start off on all the questions, one of the things that really popped up to me was this idea of why in 2021 are we still needing to have these conversations? Because, I think, well, in 2021, we should be here or should be there. But then, of course, we get so caught up in the shoulds and the coulds and the woulds. So, but I want to hear from you guys. Like, why is this conversation still needed? Why are we meeting here today? Anyone?
I guess that.
Go for it.
Yeah, for one thing, I think we're still here because there's still stigma attached to it. I mean, for example, we know there's been COVID and there's HIV, and you see how people are so freely to talk about COVID. I have COVID. I just got tested COVID, but they can't do that about HIV because there's still stigma attached to it. So that's why we're still here. So until there's no more stigma, then we won't be able to talk about it, because people will be able to go get the services they need without a fear of being stigmatized. That's why we're still talking about it. How many years now?
Right. And I agree, to build on that, and in the framework of women, in this conversation, women, we carry the world, right? Like we do everything. And it's just so hard. I think there's so many more barriers for women. Well, I don't say more. There's different barriers, I should say. Let me correct that. There's different barriers of just to get tested, and providers, and the whole thing of we can talk about lack of childcare to get to a testing event, or the whole nine. In my context, if there's any type of coercion or violence, and specifically in my project, just even asking to test, or asking to get a test, or asking to use a condom, it's just not, Sophia had a very good, why are we still talking about this? And Helen, stigma is absolutely correct. And all the things that we work really hard on, right? All of us here, and the people who we work with have worked how many years upon years, I think Amy said, she's been doing this since, in the ER, many moons ago. Like, it's just like, but it's just like, the harder you work, it seems like there's just more. There's always a new barrier or a new issue that pops up. It's never clear cut, HIV. It's food, or food scarcity, or food insecurity, I think is the correct word. But or it's just depending on your zip code and all these things. It's just, there's always just new adjacent issues, I guess, is what I'm trying to say. It's never Never easy, right?
Never just one thing.
Yeah, never just one thing ever.
Mm-hmm.
It's definitely never one thing. And to kind of piggyback off of what Melissa said, we definitely, when I see some of my patients, both those interested in PrEP and those who are HIV positive, and even those coming in just for STI testing, you know, a lot of the times our women are taking care of their families and putting their mom's health and their kids' health and their kids, you know, all of their other responsibilities. Women tend to wear multiple hats, quite often all at the same time. So reminding women to focus on their sexual health is very, very important, and something that we definitely cannot, number one, cannot forget about, but we also need to make sure we're not putting on the back burner during this pandemic, because a lot of things have been put to the side, healthcare related and prevention related, primary prevention related, because of the pandemic and you know, transmission of the numbers. Hopefully the numbers will continue trending the direction that they are, but that's definitely come into play with some people not getting some of the services that they've needed.
Oh my goodness, that's a whole
Yes.
So we actually got a question from Facebook, from Octavio Saraga, I believe. They said, "Go Melissa" on Facebook.
Thanks, Octavio.
And Matt Hines says hi to Helen on Facebook as well. So one of the comments was, Octavia Saraga says, one of the hardest time I have as a peer navigator is helping women access reproductive services. Oftentimes, I feel that our clinics are heavily guided towards the G and LGBT community. Where can I recommend women to receive things such as pap smear, birth control, etc., that are low cost or free?
Very good question, Octavio. I think Helen and Amy, as you know, that offer direct services, could probably provide a better guided or better answer to this. But you know, I think Texas in a whole is as a whole is just lacking in women's health, right? Is a non-Medicaid expansion state and things like that. So we don't have access to a lot of things. Mm-hmm. But I'll definitely, there's a couple agencies that I know that are doing birth control for free or online now, that I will make sure that either Sophia or Brandon mentions in the comment section, that I think could be helpful.
Awesome.
Yeah. For me, it's not a uniform, because like if women want services, you have to assess where they live. First, I have to figure out where they live and if they have coverage or not. Mm-hmm. So we have to do a lot of research, because I found out that if you just send women or anybody, you send them to get care, and if they don't get what they really need, they shut down. Mm-hmm. So you know, that's what we do at the Afiya Center. We want to research first where we're sending somebody. So it's not uniform to say I'm going to send everybody to this place. So it depends on, you know, where they live and really their needs are. We just go to different places, but there are services that we can send them to.
So if somebody came to the Afiya Center, you would guide them from there. So you get their information and then they would go from there. Is that correct?
Exactly. You know, because we have to make sure that we are making the informed, you know, referral for them. Mm-hmm. And we do get a lot of people who don't even have coverage at all. We get immigrants that don't even have anything. Mm-hmm. So if I send them to a place where they're going to say, oh, you can't get services because we don't have documentation, we don't want that. Mm-hmm. So we make sure that we are sending them to the right place. So yes, we do have resources where we send people.
Okay, awesome. Can you even mention why there's that discouragement? Like, why if someone goes to the wrong place, there is that sense of like, I shut down, I don't want to go anywhere. Can you explain a little bit more about that?
For the clients that I have, pretty much it's like you feel, it's almost like you feel like you're discriminated, even though sometimes you're not discriminated, but that feeling to say, oh gosh, you're not going to take me. And sometimes that maybe as providers, we don't take time to explain to the people why we are shutting them down. Instead of just saying that you need to get this information before you come back, we just say, oh no, go, we can't take care of you because you don't qualify. So yeah, that makes somebody else to even give up. So we're dealing with people who are broken already. You know, they're coming to us, they're broken already. So to get that negative at the beginning, it's not good.
No, you're gonna say no. Never mind. I'll just go back home. I won't do
it. The problem is as a result. So we say no to them. We can't give them service, and then they end up in the ER. So the ER has no choice but to take care of them. But we don't want that.
And one thing too, when they go to the ER, the ER is only going to make sure you're not going to die right now.
Right.
That's literally the job of the ER. They don't do any preventative. They don't do any. They don't do any pap smears. Like sometimes women will go to the ER because they're having pelvic pain or bleeding, and back when I was a nurse in the ER, they would come in and we would do a pelvic exam. The doc would take a look in to make sure everything looked okay, and may have taken a sample if there was concern for like an STD or STI. However, they would come out saying, "Oh yeah, I got a pap smear." Well, no, you didn't. You did not get a pap smear. They got a look-see sometimes. So, you know, a lot of the times, and I feel a lot of the times, especially younger women, don't necessarily even know what healthcare they need or what healthcare they've gotten at this point. You know, so I've had patients tell me, "Oh yeah, I had a pap smear at the ER." I'm like, "No, you didn't, baby. I promise you didn't." So we can get records, but I promise you didn't. So we definitely have quite often, you know, the services, and I can only speak from what we offer. Our patients who are HIV positive, absolutely, we take care of all of their pap smear, birth control if they want it or need it, all of that. We don't have any services for the general population at Prism in regard to pap smears. I probably have the same idea that Melissa had mentioned. There are some online subscription services where you can get birth control for a pretty reasonable rate. I believe a couple of the young women that I know personally, not through work, use Planned Parenthood has an app now as well. Of several of that there become several, and they advertise on Facebook quite often. That was actually how I'd seen one of them the first time I saw them. So there are some services out there. They're unfortunately not free, and they're not going to get a full like a pap smear. But they could get birth control, which is preventative, because if you're preventing pregnancy that's not currently planned for or intended, that's at least one step they can get taken care of.
Right. And you know, like the things that we see like on Facebook or advertise, that we assume that people have Facebook. We assume that people have access to where they can mail them the medication. We assume that they can read.
Yeah. Very good.
Yeah. So it might be there, but not everybody has access to those.
No.
Right. Unfortunately.
And I feel too, they don't necessarily know the language. Like Amy said, a pap smear, I've worked in healthcare and been a social worker for a while in different organizations. So like I have a leg up and I know how to say it, I know how to educate on it. But, if you're, we all know unfortunately, I bring up Texas again, but it's lacking, sex education is lacking and things like that. So how does a young woman know that she even needs a pap smear, or is it this time, or is it, even when I was in my mid-20s or mid-30s, when I had my son, and they're like, oh, it moved from, it was a yearly thing to just a every 3-year thing. I was like, oh, when did that recommendation change, or, something like that. And this is me coming from a place of privilege and having access to a private physician and things like that. So it is like educating women on what does that even mean to you? Or what does, not just coming in when there's symptoms, true preventative care, which we lack, unfortunately, from A to Z, not just in sexual health. And so, yeah, I definitely agree.
Yeah. Well, thank you guys. So we have some more questions, which is awesome. So someone did say that Nurex is another one for is a birth control. Someone also mentioned that Planned Parenthood offers like pap smears and birth control as well. But that also then leads me to a whole nother thing, which is which I'll get into in just a second after we answer this question. And then we had Alex Ortega asked, says, I've spoken to quite a few women about PrEP. Many don't want to do it. What can we do to encourage more women to utilize PrEP?
That's actually something Project Safe Connect is working really hard on. Because if women are experiencing violence in their relationship and they're at risk for HIV, for whatever reason, even if their partner is living with HIV or their partner is living, is controlling them and just not allowing them to do condom negotiation, where it's really, they're not the target of a lot of media or ads and stuff like that. So we're trying to create some and speak the language in Dallas County and say, hey, let's see, or do you need PrEP, and can you take it safely? Can you take a pill safely in the context of a controlling or violent relationship that you need to take? Sometimes, when you talk about reproduction coercion, I'm sure Helen, Amy understand, like, women can't even take birth control if their partner finds out. That could be a very horrible thing for them. It could be a violent event. So it's kind of a case-by-case basis, and we have to talk about how can we get what you need to use safely in every day. And as people know, taking a pill every day, if you take out the violence, it's hard to remember to take a pill every day. Or that's a barrier in and of itself. People don't like take medicine every day. And then you have the added barrier of being a woman and having all these other things go on. Don't have a great answer for that, I guess, is what I'm trying to say. But I think it's a need. I think that hopefully now that the conversation has started, I've heard more about it in the last year. And we're targeting women with some media and trying to talk to them about it specifically. And I think we're just not talking about it enough. We've gotten to the level where PrEP, my husband saw a commercial, I think during NFL, he's like, why is it I saw a PrEP commercial during the football game? Like, it was a commercial in between the quarters, and he was just like coming to get me out of the room. Look, they're talking about PrEP. He was just, and I was like, that's really exciting. Like, I didn't know, that was a perfect time to talk about that. Gathering a lot of male audience members, but it was in the context of, the G and LBGT. So I don't know that women even know that it can be for them. So it's having conversations like these that are super important and broadcasting them, and so they know, it is for you. If you need it, there's a way to do it, and we want to help you. Let's talk about it. It is. That's a very good question, Alec. Like, it's just, we got to keep talking. We got to share the information.
I agree. I would imagine the PrEP that was in the advertisement was probably Descovy, which is not approved for women. So they're not going to market it to women.
Yeah, exactly. Yeah.
Their marketing is going to be to the G and the T and the LGBT. So and unfortunately, the company that makes the medication is who puts the ads out, and they, obviously moved their advertising dollars into the newer drug, and it does have a safer safety profile, but you kind of have to weigh the pros and cons of potential HIV infection versus a drug that's been around for a really long time, and we've given fairly safely for a really long time for HIV care. That's kind of gotten a bad rap because now we've got this, new and improved drug that its claim to fame is it's safer, but that doesn't mean that the other drug is necessarily harmful. It's just older. And when taken for, not for a lifetime, like with HIV care, the concern for the safety is not as, it's not as great in somebody who's going to be taking it for, maybe 2 or 3 years versus somebody who's going to be taking it for 20 or 30 years. So, kind of the pros and cons you have to weigh out. So that some of those are some of the conversations that you can have with women. And also, I will say there is currently a study, there are several studies looking at different forms of PrEP, and the drug companies are looking at new, potential new developments for maybe at some point an injectable PrEP that's a long acting. Of course, some of those things may be pipe dreams and may never come to fruition. We don't know. But potentially getting into one of the drugs that's currently being studied, and we actually have the study at Prism Health. So if anybody were interested or had anybody who might be interested, they could be referred to us. But there is the potential for a once monthly version of PrEP. So that's being looked at specifically in women. So I think maybe as more options become available and more marketing comes out, again, the drug companies have way more dollars than we do.
Infinite, right? Just like
right.
infinite number of money, yeah.
So finding ways to get more, again, more national or more, broadcast ads would be a way to, potentially, as Melissa said, they're still trying to figure out what to do to try to help get, maybe some, brochures or something like that specifically frame PrEP in a in a women's environment.
I'll say too, like working with women in the African American community, even the Afro-Caribbean community, most people don't know about PrEP because the way the message is written, that's it's almost like for people who already know about these things. So maybe if we can change to put it in a way that people like can understand it, which might mean too that if we do outreach about it, we have to talk in a way that people can understand and trust you, because they have to trust you too. Because I can go to a community where I'm not trusted already, they're not going to listen to me. So you have to build that trust for people to actually even trust what you're bringing in. So we already know people are already sensitive about taking medication. They're already sensitive. What are you trying to do to me? So if we talk about it in a way that they can understand, I think maybe we can reach more people. Right now, I think it's written in a way that only us as providers, we can understand it because this is what we do every day.
Yeah. Well, for those that don't know what PrEP is, could someone please tell me what PrEP is? Because I just realized we all know what it is, but we didn't actually say this is what PrEP is.
That's fair. I can speak to that. So PrEP is basically Truvada. Truvada is the medication that's approved for women, for cis women. Truvada was old HIV care. It's been HIV medication. It's been around in combination with other HIV treatments for many, 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 many years, since the early 2000s, if I remember correctly. It was in the world whenever I came at HIV in 2008. So I don't remember the exact when it went to, but it was either late 90s, early 2000. It helps to block and basically block, to kind of just break it down as simple as possible. It helps to block the HIV virus from being transcripted in the cell. So if you do get exposed to HIV, the chance of the virus actually infecting your CD4 cell and then turning your CD4 cell into an HIV factory, which is basically what HIV does, is significantly less. The numbers vary somewhere in the upper 80s to mid to low 90s if taken correctly for prevention. And of course, when we talk about PrEP for prevention, it is only going to prevent HIV. It does not help prevent gonorrhea, chlamydia, syphilis, trichomonas, herpes, HPV, all of those other things that are out there, and we see lots of. However, HIV is probably the most costly of it definitely is the most costly of those sexually transmitted infections. So it helps, and absolutely a lifelong, as would be herpes. But it's absolutely a lifelong infection and can have significant health effects if infected. So it helps to prevent HIV infection.
Awesome. My second question is, if a client comes in and they identify as a trans woman, would they also be able to take PrEP? Would it be Truvada? What would be the differences?
So with a trans woman, they have the option of, as I kind of alluded to earlier, Descovy is the newer version of Truvada. Literally the only difference is Truvada is tenofovir disoproxil fumarate with emtricitabine. Descovy is tenofovir alafenamide with emtricitabine. The tenofovir alafenamide is at a significantly lower, it's taken up better by the cell, so they can dose a lower number of milligrams and still get the same effect. You end up with less. I always do this whenever I'm talking to my patients, and I'm like, I feel like I'm flying away. You end up with less free-floating drug that's not getting into the cell. So that's how you end up having you theoretically have less side effects, not less side effects, less potential adverse effects. So both Truvada and Descovy are available to either trans women or men of any cis men, whether they're men who have sex with men, men who have sex with women, or bisexual. And the trans men would be also in the class with women, just because it hasn't been studied. And it's not to say that Descovy is not necessarily going to work in that population. It just has not been studied, so there's no data to back it up and say, yes, this is providing you this level of prevention, which is why we don't write Descovy for those people, unfortunately, and again, it comes down to the pharmaceutical companies. That's what they studied when they studied the newer version, and for whatever reason, that's who they studied the newer drug in, so that's who the drug is approved in through the FDA.
Awesome. That's wonderful. So we did get a comment from Anna Beelan. I'm sorry if I'm messing up your name. They said that Melissa brought up some good points from earlier, but their question was, what are women-centered social services doing to, one, translate medical jargon, and two, connecting women to preventative services like PAPs, well women's exams? Are there interactions available? Interventions, my bad. Interventions.
Anna Beelan brings up a really good point. Like, and you got to meet anyone where they're at. I know that, but specifically, since this talks about women, we got to meet. What do they know? What do they think they know? And where are they at? And what can we do to help? Further that education along. And sometimes too much information is overwhelming, right? It's just, and it's like Helen kind of brought, it's a case-by-case basis. I got to figure out, what do you know and how can I help you kind of come up, health literacy, as I think someone else brought up. It's, sometimes it's a step-by-step process. Maybe that day they're not even in a space to really take on more than a couple things. But I'm like, what do I need? What's the most important thing they need today? Like a triage, almost like an ER, like Amy's kind of, what do they need to know today? Can I really talk to them for 20 minutes about stuff like this, or is it a 5-minute conversation and I call every week? It's really hard to put on a one size fits all for this, especially I guess especially for women, because again, running the world and you're just trying to take as much information as you can. But as far as translating medical jargon, like Anna Beelan asked, I would say meet them where they're at and try and figure out what is the best thing for them or I don't want to say best thing for them, because I don't want to say that like I know what the best thing is, but just how can we elevate their education to a point that day that they can have, and we can have further conversations.
Right.
And connecting women to preventative service. I think that's been, and Amy as a provider might be able to hit on this, I think that's been the telltale, preventative care, right? And Helen probably too, like preventative care is just low on the totem pole for everything. We're very a reactive society. And, if you have an STD or an STI, well, you can get it treated and we have the medication, but how do we have the preventative so you don't get that STI? And there's just not enough money in the world for that. There never has been, right, ladies? Like there's never been enough preventative care for anything. And there's probably not enough interventions to bring that up. That's a really good point. There's not enough interventions to get women where they need to be and to elevate their health literacy on things. For sure.
So what we do too at the Afiya Center, we try to focus on the, like you talked about that a woman comes in with an STI and you want to tell her that we can treat it. But sometimes if we just focus on that STI, it doesn't work, because the reason sometimes it might be, okay, maybe she's sleeping with somebody who she already knows that he's at risk. But at the same time, that person is the one who is paying for the rent.
Yeah.
That person is the one who is providing everything. So that's why, like at the Afiya Center, we take our time to look at everything that's going on in the house. Because sometimes you might want to fix the food situation before the STI. So it depends, case to case, because we can say, okay, take this medication, and they can't take it because he's abusive. She can't even bring the medication in there. So we need to fix sometimes things in the back end.
How would you deal with that situation if someone is living with an abusive person, but they do have an STI and they have all these needs? What would be the first steps? What would you do if someone were to come in with that similar situation as well?
Sure. I think, for our program, we assess safety first. Are you safe to go home today? Do you feel safe going home? And then from that, if that's a yes, okay, let's talk about what safe looks like to you. And then the resources, if you become unsafe in the middle of the night, in the day, 24 hours a day, what are our options? And as you know, a lot of people don't want to call the police for numerous different reasons. Documentation, distrust in the community, things like that. So there's plenty of services available without the police involved, or plenty of, emergency shelters, counseling, and stuff like that. But let's talk about what safe looks like to them. Are they safe to go home? And can they bring a medication into their home? If they can't, can we help provide, can we do something that, they leave the medication, or do they have a friend they can leave the medication with, when they're on their way to work, or when their abusive partner goes to work? You have to get creative. And that in and of itself, I was a victim advocate for many, many years at the police department. That in and of itself is not a one size fits all. That's very different for everybody. I'm sure the ladies agree. It's, and safe to me and safe to them are two different things. Some women feel safe if they haven't been hit today, it's just very, very hard to have those conversations and talk about what that looks like. And I have to know that that's not my decision to make. I just have to figure, how are you safe? What is your biggest need? And how can we go from there? But Sophia's right. Bringing home medication ultimately can cost someone's life and can be very dangerous. So you have to figure out what's the best case scenario. Do you have a friend? Do you have access to a friend? Do you have a hiding spot? Do you have something? You have to get very creative. I mean, I've given phone numbers and, help stuff, phone numbers in women's bras, written it inside of a shoe lining, or something, so they know when they are ready, they can call this number or things like that. So, it is. It's a very tailored conversation for each woman. to talk about those types of things. And we got to talk about the partner. Like, sometimes I'll ask them, is your partner computer savvy? Like, do they know how to check your history? If not, could you save it over here? Could you save this phone number as under a different name? But some can't even, the cell phone can't even look like it's been used that day, or something. Like the minutes are checked, the texts are checked, there's trackers, like the apps are very sophisticated, they look at everything and stuff like that. So it's really, I'd have to say, and I hate to say I can't answer the question, it just really depends on, I got to, talk to someone one-on-one and figure out some more things, and get some more information, kind of like Helen's brought up. It's not a one size fits all, unfortunately, when it comes to abuse. It's really not.
Okay. That was a lot. I just want everyone to take a collective.
I know. Well, that being said, and I do want to say, there are victim advocates that specialize in this, and I can share some website. I can share some specific advocacy. We can advocate on our stuff, but there's whole professions that just work on safety and talking about safety plans and stuff like that. So it's a bigger conversation and things like that. So,
of course.
Yeah. And I also like women, when when they know that somebody is there to support them, they're more empowered to do something. Mm-hmm. Because they might want to get away with the situation, but then they're like, where am I going to go? But if they know that they have support, they know that somebody got their back, they're gonna take care of themselves somehow.
Someone just to listen. Sometimes they just, today I took a phone call, they just wanted me to listen to what they had to say. They weren't ready to make a move. They weren't ready to do anything today, which is absolutely fine. But they just wanted someone to hear what they had to say. And I'm like, I can listen.
That's why we don't need to make the system complicated, because when somebody's in need, they need it like now. Because if somebody calls, they're like, oh yeah, you need to call this number and then call this number and get an approval from this person. By the time you do that, somebody is in trouble.
Yeah.
So sometimes the resources, we don't have them right there. That's the problem too. Sometimes when we don't have the resource right there.
Yeah.
Because if we have to go to somebody else to do it, then they get discouraged. Before you know it, we're gonna hear that, oh yeah, she's in the hospital, somebody beat her up.
Yeah, definitely.
So what I'm hearing is building that trust is the most important thing over anything else.
Yes. I mean, I have this, you got to ask the question, are you safe at home? If you don't ask, you'll never know. And then some women, and I want to put a caveat, absolutely men are victims. I don't want to take away from that at all, but just in the framework of this conversation applying to women, some women, like, they're like, look at me. And I'm like, do you feel safe at home? Or are you safe to go home today? They look at me and they're like, no one's ever asked me. I can see they're like thinking, and I'm like, it's okay, take your time, and then what does safe look like for them? So yeah, it is, if you don't ask, kind of like an HIV test. Have you been, when's the last time you've been tested for HIV? And, you have to ask, you have to start the conversation for sure.
Yeah. I think in the world of HIV that we all work in, we get very caught up on the testing part, the very clinical part, and we neglect all the humanness of it.
Yes.
Yes. So I have some questions. We have a couple actually. There's one that says, do you think that clinical language and terminology scares women? I know that some women are just confused of what a pap smear is, let alone medication.
Yes.
Yes.
Yes. I would say that doesn't even have to necessarily be women, people. I mean, people don't know what, a lot of the times and I catch, even though I've always been, tried to make a concerted effort to, explain things in ways that anybody can understand, I still sometimes fall into the language that I know whenever, the language that's more comfortable to me, which is not that's necessarily going to make any sense to the patient. So I definitely, yes. And there are times, like I think Melissa had mentioned, sometimes you know, and that we give patients information overload, and I try to take cues from the patient whenever I'm talking to them. And if I can see that they've kind of got that glossy, glared look on their face, and they're like, no more can go in, it's all going to go out, I just kind of shut it down and go, okay, we'll just deal with the rest of that the next time. And sometimes you have to do that. You have to take things down into pieces. I will say, you know, a lot of health literacy, you've got, you know, health literacy is a big thing, and a big piece of healthcare, but as is just literacy. You know, most people, or most of the medical, handouts, patient handouts and so forth are published at like an 8th grade reading level, but when it comes to health care, a lot of people function at like a 3rd grade reading level. They may understand all of these words, but they have no idea what they mean. So that's where we almost have to encourage our women and our patients in general to ask questions if they, and I will often, as I'm explaining something to a patient, like how a blood pressure medication is going to work or how their HIV medications are going to work, I will stop and say, does that make sense? Or do you have any questions? And try to make sure that what I'm saying makes sense to them, because I don't want them to walk out going, well, she said to take the blue pill. And you know, and I try not to use the blue pill or the yellow pill, but we have some patients who don't even can't even tell you what their pill names are because they can't read them. We have some patients who are truly have no reading level whatsoever, and get creative and create pill charts where we'll, cut out a picture of what their pill looks like and a sun and a moon and which one they're supposed to take when, and make them a nice little chart. And we've had luck with that. So sometimes it's a matter of making sure that you're understanding again, meeting them where they're at, understanding what their level of comprehension is, so that you can give them that education. Because if you're not giving them the education at a level they can comprehend, you didn't give them anything.
I think often every time I've been in a doctor's appointment and people say I understand, I automatically say yes, even though I don't. Right. And I think that's also a big piece of it, is like just being willing to say, no, I don't actually understand. Because it's scary. And that's a whole, like, as women, we're supposed to just like power through and be okay and understand everything. And that's just not the case a lot of the times. We're, humans.
Right.
And you get intimidated, people get intimidated. You go to the doctor, they're almost at the door asking you questions, and before you answer, they're out of the door. So, like, I encourage people to write down their questions before they go, if they can, they write down the questions. And so before I started, doing case management, I used to be a peer mentor. I used to work at exams, by the way. I worked at exams then. For 13 years. I worked at exams for 13 years. But before then, I was a peer in the clinic. I found that women were telling me things that they didn't tell their doctor. Because when they go in there, the doctor say, are you taking your medication? And they can see that the doctor's face, he wants to hear that I'm taking medication. So they're like, oh yeah, I'm taking it. Oh, I'm doing everything okay. But then when you meet a peer, you are talking on a personal level. They're like, you know what, I'm not taking it because it's making me sick. Why didn't you tell the doctor? Well, I don't know if they were going to be mad with me. So sometimes we underestimate the power of a peer person in the clinic, because the peers are more productive to give the doctors or the nurses the information from the clients, from the patients.
Yeah.
Because it is scary. I mean, even all of us, sometimes you go to the doctor, they ask you questions. By the time they get out, you're like, I should have asked about this after the doctor has already left. So that's another resource too, to like use the other people that they're familiar with. If they are part of the system. I know with all the HIPAA and everything, if they're part of the system.
We just got a comment from Luis, and they said, an individual's stability with their behavioral health and basic needs may compromise the importance of what information they will walk away with. And that is right on.
Absolutely.
100%, yes.
Absolutely.
Yes.
Yeah. I've had patients who have been, with not able to take their medications every day because they've got too many things going on and they're just overwhelmed with life. They're homeless and they don't know where they're going to sleep tonight. And they haven't eaten in 3 days. And sometimes I'm like, you know what? Let's put your meds aside. Let's not worry about trying to take your meds. I'm okay with you going off them. I don't want you taking them every other day, but if you need to stop your meds, I would rather you stop them than take them spotty. Let's get all of those things. I'm not the person you need to see today. Let's get you to the people who can help find you resources for housing, or I can fix your blood and your virus, but I can't fix your housing and I can maybe find you a granola bar, but let's find, get you some snacks, get food, and then move on from there. Because yes, that kind of comes back to the whole Maslow's hierarchy of needs.
Yeah.
If you don't have your basic needs met, you can't build on that pyramid at all.
No, you can't. You really can't. You're stuck at the bottom. You're stuck at the bottom. Yeah, I think we need to stop focusing on that one thing. You say, okay, you gotta take your medication in 30 days. Come back in 30 days. I want to hear that you took them 30 days. And yet 15 days she's homeless. 15 days she's crying.
Yeah.
So we need to focus on the other things too. Yeah.
Yeah, and we use, and not to bag on providers, but we use non-friendly, like patient non-compliant. Well, no, it's like those words, and they go on the chart, and it's like, no, patient's not compliant. Patient's scared for her life. The patient is scared, for her children. Let's look at the hierarchy of needs. What is going on? Or, patients miss appointments. Just for me, coming from the IPV world, incident partner violence, stuff like that. If a client misses an appointment, I'm like, okay, are they alive? That's my first instinct is, and sometimes I overdo that, or if somebody doesn't go to work or something like that, because that's the world that I work in, and the clients that I have access to. And, other people are like, well, she's just not compliant. And I'm like, no, I don't, and no provider truly means, nobody got in this work to do harm. Like, everybody got into medicine or got into social work, got into advocacy or, case management, peer services, whatever the case may be, to do some good, to try and change a system or just, add value to the system. And we all come from these different backgrounds, which is great. And I think that we just forget that we're all, we're all working together. And sometimes it's just, it kind of, butts heads, or not even that. We're all just in our kind of.
No, that's true. That's true. Because now it's almost like, as providers, at some point we need to remember that we are here, for the clients. It's not a matter of who gets more clients or who is doing a good job, and it's all about the numbers. So sometimes, it might look like that because people are trying to meet the numbers, but sometimes you got to put the numbers aside and worry about somebody's health, because that's why we're here.
I hope one day I do not have a job in intimate partner violence. I truly do. Like, put me out of business. That is fine. And I'm ready to not work in that field. I want it fixed, but it we just keep every day, just keep going. Right. So,
We have some more comments on here. Felice says, great tip. Writing things down is also great for processing what were they doing before I got all tongue-tied. They're going through and plan things out. There we go. They also said, or providers may just focus on fixing the surface problems, medication, and not addressing at the other underlying factors or concerns. And yes, that happens a lot.
Well, and everybody has their part, right? Everybody has a job to do, and you don't want to ever feel like you're not doing your job, and we all have different roles, and it's just trying to find and work together. I think the women on this panel, we're all, great in doing what we can and stuff like that. and even the HIV world and just in North Texas, it's a small world. We're all, if you think about the agencies, we all kind of know each other, know of each other, know someone at that agency and stuff like that, which is great because you're really working on that. Mm-hmm. And I, as a social worker, always say, I just barter. I'm just like, what do you need? What do I have to give you for it? Or my client needs this, but I can get you maybe an early appointment if you help me with this, and things like that. I was like, it's just a fancy bartering system for providers and things like that. So, yeah.
Just a bunch of people trying to figure it out.
Yeah, right. Okay, right.
Everybody else.
Yeah.
Okay. One of the couple more questions we have here. One was, what is PEP? How can I get it in case of an emergency? Is there something I can take that is more long-term? And if so, what is it? Where can I get it? I know
that's an Amy question, I believe.
Amy question.
So PEP is basically taking an HIV regimen for 28 days for a month. It used to be longer than that, but because of medication advancements, medication access, the medications that we have work a little more directly and help to prevent an HIV infection. The chance of, and I'm sorry, I don't know offhand what the percent of reduction of risk is with PEP. I personally have never had a patient do PEP, and actually have not had very many patients do PEP, but haven't had a patient do PEP and end up testing positive at the end. So that's 100% for me.
Right.
But it is, it's not really a good solution for HIV prevention. There is a longer term, and we talked about it already with PrEP. Like I said before, there is definitely a, there's movement to hopefully make that better. One of the really, really important things with PEP is that it is very time sensitive. PEP has to be started within at a max of 72 hours after the potential exposure event. So if somebody has, an unprotected sexual event on a Friday afternoon after work, 6 p.m., Saturday 6 p.m., Sunday 6 p.m., Monday 6 p.m., you're over your limit. So if you've waited until Tuesday to start looking at to go, oh my gosh, I just realized that I don't remember exactly what happened, and I don't know if a condom was used, or I don't know his status, and I don't know a phone number, that kind of thing. It's not the best thing to happen, but it happens. Happens a lot more than we probably realize. Then you end up with, honestly, usually the ER is going to be your best and most timely resource. One of the problems then becomes getting the medication paid for and getting the medication covered and all of that. So of course, if you have insurance, generally you can get PEP covered. One of the fun things that happens is when insurance wants a prior authorization, because, they want some paperwork filled out, and they'll get an answer back to us within 48 to 72 hours.
Yeah.
If they didn't walk in the door 5 minutes after they had sex, we're out of the window.
Yeah.
So insurance is fun. Luckily though, most of the insurance, or most of the companies that make the HIV meds do have programs that will help people who don't have insurance. I will say that they will cut you off if you've used them more than once in the last year. I've had a situation where they do not want you using PEP for prevention ongoingly. It should be an emergency situation only. And I will say that a lot of people who speak about PEP there are two PEPs there, I guess. There's and PEP, let's go ahead and actually define that. PEP is post-exposure, P for post, E for exposure, P is, the last P is prophylaxis. Post-exposure prophylaxis When it is related to a sexual exposure, it is non-occupational. It's like, what is the word? Brain left me. Non-occupational post-exposure prophylaxis. If you work in a healthcare organization or have come into it ended up with a needle stick situation, that should be handled through your health, through your employer, and that should be handled through, number one, it needs to go through, like, to cover you if you did get infected through work, so that you've got workers' comp, protections and all of that. However, if you go and get, if a person goes to the ER, and again, I'm just kind of talking about all of the bad things that happen, but a lot of the times people will go to the ER and walk out with a prescription. Parkland is really great at getting post-exposure folks through. They will see them through their, is it UCC? Their urgent, basically it's their urgent care version of their ER.
Right.
And they will basically see them, draw a baseline labs that need to be done to start, and give them a prescription, and they walk out the door with a paper. That is not a pill they can put in their mouth. They now have to figure out how to get this paper filled. Yeah. And if they go to the hospital Parkland or the hospital pharmacy, they may not be able to get there's paperwork that has to be done to get the patient assistance programs done. So once you get your PEP covered, then you still need follow-up after that. So the problem is there is no perfect solution, and I do not know what all the resources are that offer PEP currently. But there are, we've done it on a case-by-case basis at Prism. We don't advertise that we do it, because we would much rather get everybody on PrEP as much as possible. And a lot of the times we don't necessarily have, getting somebody in and for that appointment, we may not always be able to make that happen in the time window. So quite honestly, generally the ER is I don't want to say I hate sending people to the ER because I work there. Yeah. But it is getting PEP on board as soon as possible is technically an emergency. It needs to happen as quickly as possible. I have had some folks who had access through a primary care, their primary care doctor wrote it for them. But quite honestly, I had a coworker who had a needle stick, and when he went at the urgent care that he had to go to, they fumbled through looking up the guidelines right there in front of them, because it's not something that everybody knows how to do. I actually had a coworker who works in an ER text me urgently the other day. She's like, me and the doc, neither one of us can find the answer. What do we use? Like, these are the drugs. And there's I'm not naming a specific drug for a reason. There's several different options. But getting the meds on board as soon as possible is the most important thing. I don't know if maybe Melissa or Helen, if either of you guys know of any great resources for PEP that can get things done more quickly than we can.
Well, just the only time I've ever, my first exposure, but into HIV is I specifically worked sexual assaults at Parkland for 10 years. So that was, that PEP was my education into HIV, right? Because I specifically worked domestic violence, intimate partner violence, homicides, and sexual assault. And so that, it isn't, like Amy said, it is an absolute emergency. The 0 to 72 hour window, that has to be stuck to, of course. It is payable by Texas Crime Victims Compensation if you're a victim of sexual assault. So that is, and that's a very long conversation that is, but we can help you with that if that's need be, or I can share some information about the acronym is CVC, Crime Victims Compensation. If any organization needs information on that, I can definitely help that. but usually it is done in the ER setting. I've never seen it in any other setting. I've only seen it in the ER setting. And so that was a standard of care if you were sexually assaulted, male or female. They offered it. There was, of course, you have to do the liver labs, and I might be saying that wrong. I'm sorry, provide Amy, but you have to do some labs. You have to do some labs that go along with that because the providers won't provide it in the ER setting if there's some blood level issues, specifically, I believe, with the liver. But it was a standard of care for women and men who are sexually assaulted, and there was it's become faster in the last couple of years since PEP was available, but Crime Victims Compensation will definitely pay for it. And there's some hospitals that have SANE programs, which are sexual assault nurse examiner programs that kind of fast track it because they've got the system in place. So, in the computer systems and Epic, it goes pretty fast, which if you're sexually assaulted in the state in this North Texas area, Parkland, absolutely 24 hours SANE. You can get an exam, Presby, Dallas,
Presby
Plano, yes, in Collin County, and oh my gosh, Methodist. So there's like specific programs for this, and this is for sexual assault, not just exposure or like needle stick or anything. They're specifically to men and women who've been victims of sexual assault. So they have a fast system. Not to say that the other ERs don't or don't know, but these places have very updated protocols and do them, unfortunately, on a daily basis. Or at least, every other basis, they're seeing men and women who are victims of that crime. So they have it very fast tracked. They can get at the hospital, pharmacy. They get a specific color, I'll speak for Parkland, because they get a specific color prescription to know they go to the front or go to the side to give that medication and we're able to put, I don't work there anymore, but you put in the system CVC pending and things like, there were some ways to get it done and get it done within that 72 hours. But like I said, those are unique situations. That's unfortunately not necessarily the norm, I guess. Those are, very horrible, unfortunately, events for sexual assault. So if that is a concern, or if somebody does need information on that, you can, and I'll share our Project Safe Connect information, but there is the RAIN National Sexual Assault Hotline. There's a Texas Sexual Assault Hotline those victim advocates are trained and can talk about it very easily. But time is of the essence, as Amy said, just like Plan B or anything like that for PEP. If there is a sexual assault or worry of that, then Plan B is also offered in those situations. So, if you have a client that, is talking about that, I think the first thing you need to know, if you're asking those questions about sexual assault, incident, partner violence, is a time frame with sexual assault. When did this happen? And you got to count the hours out. And sometimes women, and speaking about women specifically, women don't know, Friday between this time and this time. So, we always try and give them the benefit of the doubt and round to what we hope would be 72 hours and things like that. But as we know, that's the most underreported crime in the United States. So, a lot of sexual assault isn't disclosed until much later in life, when women feel, that they feel safe enough to have that conversation, right? Or tell a friend or somebody they trust, a family member or an advocate, or, in counseling it comes up, or a medical thing. So time is of the essence. So if you do encounter someone who's been sexually assaulted, that's the first question I would ask them. When did this happen? Can you tell me a time frame when this happened? And if so, they may need to go to an ER setting, and then do they want to report to the police? Do they not want to report to the police? Those are all questions that a victim advocate that's trained that would go out to a sexual assault and have those conversations. But there's absolutely a way to get that information. You do not have to make a police report. I just want to make that. You do not have, the law has changed. It changed, oh gosh, I can't remember the year, but the law has changed. You can get a sexual assault exam and collection of evidence. You do not have to make a police report. You do have a 5-year time frame to report that crime. It goes, sorry, I don't want to covet this information or take this time away from all the other speakers, but that that kit then goes to DPS in Austin. It's held for 5 years, and then you have that time to report it to your local where the agency where that sexual assault happened. They'll recall the kit, and then they'll have it analyzed. But you can still get the services that go with, like the Plan B, the nPEP, the PEP, excuse me, and things like that. You don't have to necessarily have the police involved. And I know that is a big concern, especially for women.
Mm-hmm. Yeah, because at that time, what's happening to the woman?
Exactly. There's a lot.
Because I mean, like if somebody tells you if that takes 5 years, what happens to the woman at that time?
What happens to the women, like during the 5 years that they're
because if it's not reported, if police is not involved, that means he's still around somewhere.
Yeah, he is, and there. So it could be a stranger, it could be someone they know, it could be an acquaintance, it could be a lot of things. So safety, again, that's where the safety conversation comes in and things like that. But before this law change, it was a miraculous Hail Mary pass in a legislative session. I want to say 2010, but don't quote me on that. That because you could not get collection of evidence, you could not even get access to care if you didn't make a police report, because it's all tied to funding, right? And stuff like that. But now there is a way, and so I do advocate for that, because women may want to get the collection of evidence, but they're not sure what they want to do with their story, right? They don't know. Do they want to share it with the police? Do they want this person investigated? Do they, where are they at? Are they ready to even deal with this? But collecting that evidence and having it sit, so it's not, it can be 5 years, unfortunately, is a number, because, evidence degrades, and, it's a scientific thing that's been brought up, and then you have statute of limitations and different issues like that. But there's a way. So, and so there's, like I said, there's victim advocates that specifically deal with this, sexual assault advocates that can help. But if you have, I guess, if you work with women or men who say they've been sexually assaulted, I think nailing down a time frame and then going from there, and reaching out to your local rape crisis center and asking next steps. Reach out to me. I'll share my information, and I can walk you through the process. But there is a way to do it if they're not ready to talk to the police, and a lot of people aren't. And it's not the right time for them. So then you assess, okay.
For some people, there's a shame too, because a woman comes in to say, already the women are stigmatized. They're like, oh, what did you do to get raped?
Yes.
What place were you in? Were you at the club? Oh, that's why you got raped. Things like that. That's what makes people not report sometimes. I'm not saying that's a right thing, but I can see that being a barrier too.
It is the most underreported crime in the United States, and that's only data I have. I'm sure, the world, but I don't have data on that. But it is, and unfortunately, women. I know more about women than men, but women don't disclose until much later. And so then, when you're seeing that, maybe when Amy or Helen or even Sophia, you're seeing them for an STI, or if they're, unfortunately living with HIV from an unwanted, sexual encounter or sexual assault, it's very traumatic. And then you have to live with something that, you were forced and stuff like that. So counseling is super important, getting the whole wraparound services and things like that. But there are, we've been, as I kind of bagged on Texas earlier, and I felt bad because we're behind a lot of things, but they did get that right. They did step up and say, hey, you can collect this evidence and you can tell us on your timetable. 5 years. Just because, but that was a big win, because I would have to tell women, hey, I'm sorry, we can't help you. Like, we can't do anything. We can't even open the case. I can't even like give you a case now. I can't do anything. You have to talk to the police. And I've worked for the police department. Like, I did that as a social worker. I did that for many, many years early in my career. And I'm like, I don't even want to talk to the police. Like, I don't want to tell them, 4 hours after I woke up, I'm like, was I sexually assaulted? Was something happened to me? Like, or something like, I don't even want to talk to a medical provider. I just want to process, or much less talk to the police about what happened, not answer questions about it, or something. And like Helen said, the stigma, HIV, sexual assault, intimate, like all the stigma that goes on with that. Sexual assault is the only thing that we blame a victim for. If someone robs your house, nobody says, well, why did you have such a nice house? Why did you have such a nice car, right? Why did you leave your doors unlocked? But sexual assault is the one crime. We're like, well, where were you?
Mm.
What were you wearing? Did
How
you
much-
have anything to drink? Did you
Yeah.
have drugs? Are you a sex worker? When does
Right.
that matter? Why does that
Right.
matter?
Yeah.
It doesn't matter. It does not
And
matter
all of
one
course,
bit.
all of this just perpetuates that distrust,
Yes.
perpetuates all that
Yeah.
stuff. And now we're just in a big circle, in a big
Yeah.
cycle.
Yeah. And,
Yeah.
and we have come a little bit forward on that. I have seen the needle move a little bit. I've been doing this 16. I've seen them, I mean, a little bit. But again, you know, it just nail down the time frame and we'll go from there.
You were saying something, Amy?
I was just going to say, I assume they still do for adolescents, children's.
Yes, I'm sorry. Yes. Children. You would go to children's.
ER.
The acronym, yeah, to the ER. There's there's a program. I used to work with them, collaborate with them.
I worked in the ER before I came back here.
I'll think of the acronym as soon as this stops. But there is, and children are different. Minors are very different. Parkland we'll see, and I know we'll see 13 and up. But depending on the child and what's going on, for a rape kit or SANE exam, that can be a planned event and a scheduled event. Just there's a lot of minors, unfortunately, is a whole different ball of wax. But yes, children would be the one. And if for some reason they go to children's and children's can't see them for some reason, they will transfer them over to Parkland if there's some stuff going on. But it's a lot of information to take in.
No, it's great. I love it.
Yeah.
I love it.
I know, this is good. This is good. I'm glad we're having this conversation because I can see how there's a gap between getting the services and the services that are provided, because people are always looking at, well, how can we fill in the gaps? And sometimes we don't know. And I'm listening to what we're talking about, and I'm like, there's a gap here.
Yeah.
Mm-hmm.
Yeah. So that's why, and traditional to be working with other people other than the circle that we are used to is good, so we can, fill in those gaps while somebody is waiting for, the police to kick in or whatever, whatever
Sure.
services to kick in. Where is the person at that time? That's when, we should be working together to see what else we can do to help, people, period. Yeah.
For sure. You got to figure out, specifically for sexual assault, was this someone they knew or didn't know? And again, safe. Do you feel safe when you go home today? The person might not live in their house, but maybe they work with them, or they're a friend of a friend who live, or the same apartment complex. There's a lot of different things. So, always assess safety, assess time frame, and we can go from there.
I think, okay, so I have two questions. One, we're just going back to PEP real quick. Can women who suspect that they might be pregnant take PEP? Not PrEP, I said PEP, my bad.
Is that Amy?
That's Amy question.
Is it PEP or PrEP?
PEP, my bad, I said PrEP.
Okay. So yes, because an infection during pregnancy is really, really bad. One of the biggest risks for transmission from mother to baby is if HIV infection happens during the pregnancy, because the viral load tends to go so very high in that initial period that getting a hold of it and bringing it back down and getting the drug into baby as well is very, very very time sensitive, but also, something you really don't want to have happen. So, PrEP is available during pregnancy, and we've had some patients who have come, and even if they've only done PrEP while they were pregnant, they've come to our clinic for PrEP and had, because they had an HIV positive partner. That's hard to say. They've had an HIV positive partner, so they want to, again, reduce the risk of transmission to baby. So PrEP is absolutely able to be taken during pregnancy, and we've used Truvada in pregnancy for years. PEP-wise, you've got to kind of look at the risks and benefits and the drugs and all of that, but it's definitely a conversation that should be had. Of course, the pregnancy test needs to be taken as well. And before initiating PEP, a pregnancy test is going to be taken. So.
Okay. Thank you for that. So our very last question to kind of condense everything and wrap everything up is going to be, what can we as a community do to better link women into care, to give them the care that they need, to give us everything that we need, which I know this is a really big question, but basically to close in that gap that we've been talking about. What are some of the things that we can do as a community, but also we can do as providers and people that do this work?
I would say from my viewpoint and just in my framework that I work in, have the conversation. Don't be scared to ask. I think we're from sexual assault, domestic violence, intimate partner violence, it's just as taboo to talk about as HIV, right? Like nobody wants to talk about these things. Nobody stops at my booth at the pre-COVID at the health fair. Nobody stopping at the sexual assault booth, right? Like, I get that, but I showed up every time. You keep showing up, you keep having the conversation, you keep asking the questions, because they need to know you're there. They might not need you today, they might not need you tomorrow, but when they do, they need to know you're there. And you just are you safe at home? Do you feel comfortable with this conversation? Can you take this medicine safely? Those are the, we have Project Safe Connect has 4 questions that we recommend, I think, recommend or have kind of felt we did some testing and some research on it that were very well received in the community. And I'll be more than happy to share those that build on safety. Ask the question. If you don't ask the question, you'll never know if that's the barrier. And so just keep having the conversation. I think the gaps, there'll be a new gap every time we turn around, right, ladies? Like there's always something we've all said that. But have the conversation and let's figure out where we go to next. And I do want to say, I feel bad if I didn't answer some people's questions, but if you do have any clients that don't feel safe at home or have been a victim of sexual assault, please reach out and we'll just have to do it, a case by case basis. And I gotta have some more information. We can definitely help.
Thank you so much. Any other thoughts?
I will say one of the things that we can do, and of course, I mean, we've talked about this in clinic, some of the other, I would say female providers, because we're the ones who kind of acknowledge what the barriers that our female patients face, especially around those who have children, finding ways to either incorporate a Women's Day or and I know Parkland used to do it when I worked there a long time ago. They had Brian's house came on site and did childcare. So that the women, if they needed to bring their kids to the clinic, they had a little play area set up with toys, and they would sit in there and watch them and play with them and whatnot. So mom could go take care of her health without the distractions of a kiddo. And quite often in our clinic, especially if it's a baby, we're all passing baby around. So mom, we kind of serve as our own child care for the kids, but we'll try to take care of the kiddos so that mom can get her stuff taken care of. But I mean, we are becoming a big organization, a big agency, and we have lots and lots and lots of patients. But we still try to take care of our patients like we're the teeny tiny small clinic back when we were Peabody only, not even ours anymore. But back when we were a teeny tiny little clinic over by Fair Park, we still absolutely try to help mom out or help our women out as much as we can around either navigating around, and we as providers are able to now use telehealth. That's one of the things that we can actually say, thank you, COVID. At this point, we're using telehealth, so we're able to kind of engage with those patients who maybe don't have the ability to come into clinic or have a babysitter or anything like that. They can have their appointment while their kids are climbing on them. It doesn't bother me any. I'm like, whatever, kids crying in the background, go take care of your kid and then come back to the video. I'm going to have a cat jump up in a minute. It's okay. It's like, it's life. So, understanding that these are people with other problems and other responsibilities other than just their health, which is what our responsibility is. I'm responsible for your health. You're responsible too, but you have lots of other things. So let me kind of worry about those things and see what we can do to help you navigate health, care, and life.
Yes. Yes. Oh, I like that. Healthcare and life. Beautiful.
Yeah.
Beautiful. This was amazing. I am so happy to be here with you guys, to listen, to learn. I've learned so much, and I work here with you guys. So I know everyone else learned a whole bunch. I just want to say thank you. You're awesome. You're amazing. I know that a lot of the links and things will be shared through all the people that are behind the scenes right now, because I'm not with you guys. So I know that it'll all be shared. And of course, you can contact our wonderful guests, which I believe also their information will be given to you guys. And I think that's it. I think that wraps everything up. I hope everyone has a beautiful, wonderful evening, and that you eat yummy food and take care of yourself.
Thank you. It's been a privilege, ladies.
For having us.
Thank you for having us.
Thank
Yes.
you. Yes.
This was good.
Yes.